Hello and welcome to Noon Conference hosted by MRI Online. In response to the changes happening around the world right now and the shutting down of in person events, we have decided to provide free noon conferences to all radiologists worldwide. Today, we are joined by Dr. Tracy Kilborn. Dr. Kilborn's main areas of research are neuroradiology and infectious diseases. She is an invited lecturer at ESNR, RSNA, ESPR, IPR, ASPNR, and RSSA. She is passionate about teaching and actively involved in outreach to promote this. A reminder that there will be a Q&A session at the end of this lecture, so please use the Q&A feature to ask your questions and we will get to as many as we can before our time is up. That being said, thank you all for joining us today. Dr. Kilborn, I'll let you take it from here.
Thanks very much, Ryan, and thanks to everybody for joining in today. Just to say there was one word left out of the title, which is pediatric. So in case any of you were thinking that this was just going to be for peds and adults or aren't interested in pediatric, this is my disclosure, although I have no other disclosures. So let's start talking about the many phases of pediatric intracranial infection and what we really need to look at, not to miss in these children. Sorry, So what am I going to cover in this lecture? Well, I'm going to discuss what we see or don't see with meningitis, the complications we need to look for, and then some important lookalikes and alternative diagnoses to consider. And just a disclaimer is that in the limited time available to me, I'm not going to be including infections of the spine, and also that my hospital is a pediatric tertiary referral hospital in a low and middle income country. So therefore we have one MRI scanner. So we have much more limited access to MR than in the developed world. And also that we are not doing ultrasound heads of neonates. They are at a neonatal hospital and only come to us should they need neurosurgical intervention. So I will not be showing images of neonatal heads. So let's talk about pediatric CNS infection and suspected meningitis in a child. Well, it's a very common presentation in pediatric practice with the highest mortality rates in neonates and under fives. And we all know as radiologists, this classic referral on our risk systems of looking for safety to lumbar puncture or raised intracranial pressure. And we know that the spectrum of diseases is evolving. We have travel, we have migration, we have declining immunization and anti-vaxxers, and therefore we need to be aware of that, and also the regional differences of what's common in our own country versus in other countries, and what may be becoming more prevalent in our country with migration. And as I've already alluded to, access to imaging is important because in many places in the world, MRI is a pipe dream, and in other places, MRI would be the investigation of choice or the first investigation. So if we look at the indications for CT and acute infection, and this is around the world, and actually look at what our clinicians' guidelines actually say, I think you'd be quite shocked, because it certainly doesn't represent what most of us are getting in daily practice. So whether you look at the British, the UK, the European, the American guidelines, in most of the clinical guidelines for clinicians that they read, the contraindications for lumbar puncture before CT brain refer to a Glasgow Coma scale of less than 10. And they also specifically talk about CT features of gross generalized brain swelling, but also that it's important to note that a normal CT brain doesn't exclude the presence of intracranial pressure, raised intracranial pressure. And if we look at the most recent guidelines from the European Society of Clinical Microbiology, again, they're talking about a GCS of less than 10. And I think any one of us that got a referral for a child or even an adult that had a GCS, for example, of 12 with neck stiffness and sepsis, we'd be hard pressed to say no in that patient to the imaging. So the guidelines don't really represent what is happening for all of us in daily practice. The reality is, and I think this is probably true in most places, is that although in pediatric practice, We talk about radiation and trying not to use CT. The speed and availability of CT is a very tempting screening procedure for clinicians. There is limited availability of MRI, both in developed and developing countries for acute emergencies, particularly in pediatrics with the potential need for anesthetic support. We know that all patients with meningitis have some degree of edema, so are the CTs actually that helpful? And in all the clinicians, and by there I'm talking about the neurosurgeons and neurologists literature, they will all say that the clinical signs of pending herniation are better predictors than CT. And certainly in my own institution, our neurologists and neurosurgeons have specifically asked us not to be commenting on whether it's safe to lumbar puncture, because even if we say that a CT scan is normal, it is still a clinical decision based on GCS and focal signs as to whether or not that patient should be lumbar punctured. So I would just caution you against saying that. And the other term that comes up is radiologically safe to LP. Well, we're not doing the LP, so we probably shouldn't be saying that. So I just want to do some pitfalls, and probably one of the biggest pitfalls is neonates on CT, particularly if you're not used to looking at them. And that is because of the unmyelinated white matter. You have hypodensity. So normal white matter hypodensity is seen in neonates. And that can sometimes be quite difficult if you're not used to seeing it. So you should always try and have a reference image of a normal neonate's CT brain when you are looking and going, is this actually edema, as we see in this patient who had a venous sinus thrombosis? You can see the hemorrhagic infarcts both posteriorly and anteriorly. Or, for example, in this neonate, who was actually maple syrup urine disease, who presented with diffuse edema. But you can see how difficult it is to call in a neonatal patient. So it's a caution. You need to just be always aware, is what you're calling edema really edema, or is it normal neonatal white matter hypodensity? Then remember that in the early neonatal period, you still have fetal hemoglobin and they are hemoconcentrating. And it can look very similar to a thrombus. So don't call diffuse venous sinus thrombosis in a patient who actually just has normal fetal hemoglobin. So if there's no other features that look like venous sinus thrombosis, don't call it. And again, look at that normal CT on the left and the white matter hypodensity. So what is the pathogenesis of bacterial infection and how does that relate to what we see on imaging? Well, we get hematogenous seeding from a systemic focus of infection. Additionally, it can come via the choroid plexus. And remember that the choroid plexus lacks a blood-brain barrier. And so it's very easy for any infective focus that goes into the choroid plexus to disseminate via the CSF. And then in older patients, contiguous spread from infection in the mastoids or the sinuses or from penetrating trauma. But even allowing for all of that, the commonest CT finding that we see in children with meningitis is a normal CT. And this is particularly true of neonates who've got a very immature immune response. And this is a patient pre and post contrast CT with severe meningitis and a decreased level of consciousness. And you'd be hard pressed, particularly in the patient on the left, to say that you were seeing anything abnormal. And that's the important reason for our clinicians to be using their own clinical indicators for lumbar puncture. Just remember on CT, we've got important review areas. And I know for a lot of you that are doing this routinely, you'll go, well, we see this all the time, but just remember for those trainees that are not looking at a lot of CT brains in children, children have got much tighter, and I put that in inverted commas, appearing brains because they do not have atrophy or age-related changes. So you need to look for additional features of potential edema or swelling. So the cisterns and the ventricles, we like the third ventricle to have parallel walls, as opposed to this one where you can see the walls are becoming rounded and we're starting to see the temporal horns. And we look at the basal cisterns as well as looking at the ventricles. An important review area, particularly when you look further down and the brain looks a bit full, is to look at the vertex. Look for the presence of sulci or sulci and normal venous sinuses, because when those are absent, it's a sign of raised intracranial pressure. And then an important review we all know as radiologists is to look for asymmetry between the right and the left hemisphere and for any shifts, even if it is subtle, of the midline and the cause for that. So moving back to the signs of possible meningitis, well, brain swelling. And we know that if you have an infection in your brain, you are likely to have brain swelling. You can get enhancement of the ependyma or the leptomeninges, but that is not diagnostic of meningitis, because we know that even in patients that have got swollen brains related to having had seizures, they can have some leptomeningeal enhancement because of the edema. And the other thing to look for is some engorgement of the choroid plexus. Other clues, and this is for other infections, is to always look at the density of the CSF in the ventricles, and then look at the density of the CSF in the extraaxial extraaxial spaces and in the basal cisterns. In this patient, we can see that it's slightly hyperdense compared to that CSF within the ventricles. What does that mean? Well, if you have a patient who's got a decreased level of consciousness and has this, you need to start wondering, particularly if they are malnourished, immunocompromised, or come from a developing country, whether the infection they have might be tuberculous meningitis. And then look very specifically for contrast enhancement in the basal cisterns and in the MCA cisterns. So what are other features to look for basal meningeal enhancement? Well, you can see here, it's quite easy to see the so-called Y sign of enhancement in the MCA cistern. You can see enhancement around the brainstem. But what about in this patient? Does this patient have TBM? The patient had miliary TB on chest X-ray, a decreased level of consciousness, and meningism. When we looked at this, we were like, well, do we actually see basal meningeal enhancement? It can be very subtle. So you need to look for the things that are normal. Focus carefully on the basilar and the posterior cerebral arteries. And then a clue is to look along the anterior surface of the brainstem, and particularly the pons, because if you see enhancement there, there is no normal vessel that should be traveling there. And it's a marker of meningeal enhancement, basal meningeal enhancement of TB. Another characteristic finding in TB, and this is because it is actually the commonest cause of meningitis in the center in which I work in Cape Town, because we have TB, which is endemic in our society, is pre-contrast asymmetry. So when you can see that the right and the left hemisphere look a little bit different, and use your imagination and go that certainly the sulcal markings on the right almost look a bit hyperdense. We can see post-contrast enhancement of that hyperdensity. This is a patient with TBM. And again, look at the asymmetry here between the right and the left hemisphere. We have got slight ventricular enlargement. We've got enhancement, nodular enhancement in the right MCA cistern as compared to the left, and basal meningeal enhancement. It's asymmetrical. One other tip I would like to give you is when we see asymmetrical contrast enhancement, the patient needs to be screened for TBM. You can see the classic appearance of basal meningeal enhancement in the patient on the left, who is HIV negative, and the picture of TB meningitis in the patient on the right, who is HIV positive. We have got cerebral shrinkage, which is common in HIV positive patients, particularly those that have got encephalopathy. And those that are not yet on antiretrovirals will not have a normal inflammatory response to TB because they have got defective host inflammatory responses. In order to respond to TB, you need to be able to have T cells and CD4, both of which we know are diminished in HIV positive patients. And here is another patient. You can see the asymmetry between the right and the left hemisphere. Quite a lot of shrinkage in the right hemisphere for a pediatric patient. And when we look on the contrasted scan, we can see that asymmetrical enhancement, again in an HIV positive patient. So in a patient from a low or middle income country, or a patient who's immunosuppressed who presents with features of meningitis with asymmetrical enhancement, consider TB meningitis. And just a lookalike, don't forget, not all basal hyperdensity is TB, because in this patient we have a subarachnoid hemorrhage. Again, a lookalike, a patient who presented with seizures and asymmetrical enhancement. Pre-contrast, we can see the difference in the size of the cerebral hemispheres. We look post-contrast, and you can see there's enhancement on the right, but not on the left. The enhancement you can see in prominent and slightly enlarged choroid plexus. And clearly, yes, if we'd got a proper clinical history in this child, or if one of us had been looking at the patient when the patient came in, we would have picked up the fact that the patient in fact had Sturge-Weber. So not all asymmetrical enhancement, as you know, is related to infection. One has to know what the true clinical picture is of the patient before you make the diagnosis on imaging. So once there has been a diagnosis of meningitis, often the reason for imaging is not to diagnose the meningitis, but more to look for the complications. So what do we do with the so-called sterile subdurals or subdural hygromas? Well, the increased permeability of the leptomeninges in a patient with meningitis is going to lead to fluid seeping into the subarachnoid and subdural space. And this is particularly common in neonates. 50% of neonates who have meningitis will have sterile subdurals or subdural hygromas. And often in these patients, it's quite difficult because they may have a persistent temperature. We do the CT and we don't know. You can see in this patient, we've got quite large subdurals, particularly on the right when compared to the left. They're usually over the convexities, but they may also track along the falx. We can see in the image on the right that there has been some effacement of the cerebral sulci on the right. So there is mass effect of this hygroma. Importantly, most of them resolve on their own without any treatment. But what about the ones that potentially are infected or are empyemas? Well, we can often see in inflammation of the arachnoid as a pencil-thin line of enhancement on MRI. We see normal dural enhancement as the thicker line. But again, it's very difficult to know, is this an empyema or is this a sterile hygroma? And here is another patient. So this is a meningitis on treatment with persistent spiking temperatures. We're asked, is there an empyema? And in this case, given the appearance of the scan, is it bilateral? Well, again, remember I said, look at the density of the CSF and of the subarachnoid space, which you can see here as hypodense. We have got bilateral intermediate density subdurals. How do we know which one's infected? Well, on CT, we really don't. And this is the role of MRI. So in these patients, we're going to give contrast and potentially see that enhancement. But as we know, the best way to see pus is to look at a DWI. And as you can see in this patient, in fact, the empyema was on the right and not on the left, despite the fact that the collection on the left, or the subdural collection on the left, looked larger than that on the right. Don't forget, there is a lookalike, particularly in infants, when we see subdurals of differing density and differing density to the CSF. And that is that these patients may be victims of non-accidental trauma. And in this patient, the clue is that we can see that there is acute blood posteriorly lining the falx, and on the bone windows, there was evidence of an acute skull fracture. So it's an important differential in patients in whom you suspect a subdural empyema. Also, just to say that in a patient who comes in potentially with a picture that you think is NAI, it is also really important to exclude a subdural empyema, because you don't want to say these are subdural collections that are of differing ages, it's related to trauma, when in fact you're missing a subdural empyema. So those two will have different clinical scenarios, and it's important to be liaising with the clinicians about the infective markers. Okay, so what about complications of empyema, and how do we identify them on CT and MR? Well, the infection or the bacteria gets lodged in the meninges and it spreads via the cortical vessels into the perivascular space. So here we can see the enhancing empyema, we can see that little bit of midline shift. But it's only on MR that we start to see what's happening in the underlying brain. Very difficult to see on T2 in this case, but on the DWI and the ADC, you can see evidence of cytotoxic edema in that left frontal lobe. This is a patient who had acute sinusitis and presented with focal signs and a decreased level of consciousness. And the sinusitis was complicated by an empyema. In this case, it may not progress, but if it does progress, it can progress to a cerebral abscess because it's going to spread via those cortical vessels into the adjacent perivascular space and into the brain parenchyma. So why is this a problem? Well, because it can be very difficult to diagnose. It happens in 20% of patients with empyema, but often these patients, particularly in resource-limited settings, are going to be getting repeated CTs because we just don't have the capability to put them all on the MRI scanner, particularly if they need sedation. And in the beginning, particularly when they've been draining empyemas, you may just get ill-defined edema. And it's difficult to know, is this just edema or is it an early infarct? So in the early stage of cerebritis, we can't tell. MRI can give us an idea, as I've told you already, with the patchy cytotoxic edema, but it's still difficult to call. What we have to wait for is the later stage of cerebritis, where we're starting to get a capsule. And even then, the surgeons are going to be very undecided about going in because it hasn't actually formed pus. Obviously, once it has formed an abscess capsule, it is going to be drained. And even then, after this, we can still have residual enhancement that becomes very, very difficult to track, particularly in a patient who is having ongoing temperatures. And this leads to the patients often having multiple repeated examinations. And my own institution is guilty of this because of our inability to be able to offer repeated MRIs. And this is just where I want to bring into the fact that I'm a pediatric radiologist, and therefore we always want to try and be imaging gently and to be limiting radiation in our patients. And so just try, if you are having to do repeat examinations, particularly in patients, say, for example, that have needed shunting or draining, and that's what you're looking at, or patients with abscesses, to institute low-dose CT protocols, because now you're not looking for very, very small detail. You're basically looking to go, are ventricles bigger or smaller? Is the abscess bigger or smaller? And you could leave out the pre-contrast and just do the post-contrast scan. So the image on your right is the reduced dose scan, which I think you'll probably agree is not that different to the normal dose scan, and the doses in these are significantly different. And one other resource I would like to draw your attention to is the World Federation of Pediatric Imaging. On their website is an MRI protocol guides, and these are quick MRI protocols, rapid brains. Excuse me. The protocols have been set up with the major vendors. And when you go onto here, for example, it's going to give you options for tumor or infection and very fast scanning. And using this, you can then go to your own vendor's recommendations for the sequence parameters. So for example, here, if all we wanted to do was a DWI, it would be approximately 1 to 2 minutes, and say a post-contrast, we would be able to get a fast MRI done in 10 minutes, hopefully, in a patient who was cooperative. So it's a good resource. And if one can avoid doing as many CTs in these patients, then it is recommended. So if we do have an abscess, what sort of things are we looking for on CT? Well, we're looking for a T2 hypointense capsule. This is a cardiac patient who had fever and seizures. We're looking for smooth rhythm enhancement of that capsule. And obviously, again, the defining characteristic is that we've got central diffusion restriction with a low signal corresponding ADC, which is implying reduced diffusion of those water molecules through the thick pus. So what about a lookalike? Important, if your patient is coming from an area where TB is endemic or is immunosuppressed, a TB abscess can look absolutely identical to a pyogenic abscess. These are two different patients. The one on the left, you can see that there is some central T2 hypointensity, where the one on the right looks almost identical to the abscess that I've just shown you. These are quite uncommon TB abscesses, but they respond very poorly to treatment. The important thing is that this is a different clinical scenario. So it's unlikely to be a septic patient. Yes, the patient may have focal signs, but they are unlikely to be septic and growing organisms within their blood. And we would suspect this also based on other evidence of tuberculosis. And just to remind you, it looks very similar, although the capsule is a little bit thinner. Important, and I'm going to go on to this now, is the T2 signal, which is both of intermediate and low signal intensity here and of high signal. So this is, although it was a TB abscess when we followed it up, at the beginning, we wondered whether this was this condition. So this is a patient who presented with a low GCS, a pyrexia, this somewhat strange looking lesion on CT, some slightly hyperintense center, a peripheral rim, which we can see is enhancing on the post-contrast MRI. And on the T2, you can see it's of profoundly low signal intensity, T2 hypointense. And this is consistent and very characteristic of caseous necrosis. So in a patient in whom we see a peripherally enhancing lesion that has this T2 hypointensity, particularly in the setting of TB endemic areas, or in a patient who comes from a place where there is a lot of TB, you need to consider that it's a tuberculoma. Here is another case. It's a patient you can see has got hydrocephalus, has got basal meningeal enhancement. There is a T2 hyperdense lesion in the left cerebellar hemisphere with some peripheral calcification, which shows very poor contrast enhancement. But when the patient had been on treatment for 3 weeks, we elected to MRI it to confirm that it was in fact a tuberculoma, characteristic T2 hypointensity, and that peripheral enhancement. And this resolved with calcification after 9 months on treatment. Just to say that tuberculomas can occur either with or without TB meningitis, and they are much more common than TB abscesses. So you are more likely to see them than you ever will see a TB abscess. So what are some lookalikes of hyperdense or T2 hypointense lesions in this patient in whom we saw this hyperdense lesion with some hydrocephalus? This was pre-contrast. We actually thought that we were dealing with a patient who had a tuberculoma and was going to have basal meningeal enhancement because the patient had been admitted septic with pneumonia and focal signs. However, the clues were in the other lesions, and obviously the SWI showed us that these were hemorrhagic. And when the patient's blood work came back, the patient was profoundly neutropenic. And in fact, this was due to acute leukemia and not due to tuberculosis. This patient, similar presentation, hydrocephalus, hyperdense lesions. Again, no contrast enhancement, but this was a patient in whom the central lesion was in fact a medulloblastoma. So again, not all lesions are tuberculomas, not all lesions that present with focal signs and decreased level of consciousness are related to infection. So one of the other complications we need to consider with meningitis is ventriculitis. So how do the organisms get into the ventricular system? Well, they get in via either directly from a parenchymal source that ruptures into the ventricles, or they will get in via the choroid plexus. You get enhancement of the ependymal lining, which you can see both in the CT and MRI. And the MRI also quite elegantly demonstrates the quite marked hydrocephalus. And as you can imagine, because of the enhancement and inflammation of the ependymal lining, we're going to get reduced CSF absorption, and that is going to lead to ventricular dilation and eventually to hydrocephalus. So what is one of the other signs we need to look for? Well, it may not be that clear when one looks at the ventricles on CT or the ventricles on MRI. But if one does do a DWI sequence, you will be able to see the thick proteinaceous fluid that is layering posteriorly in the ventricles in this patient. Again, thick infected proteinaceous material in the dependent parts, which is better seen on MRI. So what other complications do we need to look for? We've talked about subdural hygromas and empyemas. We talked about abscesses and their mimics, particularly in the setting of tuberculosis in middle and low income countries. Well, we need to now consider venous sinus thrombosis. So this is more common in infants and younger children, but is still a consideration in patients that have got infection. So we have various signs that we can look for on CT. And remembering what I said to you in the beginning, you need to know the age of the child post-delivery, because in the very early neonates, you should not be confusing the hemoconcentration or fetal hemoglobin. And that's why giving contrast is very important. Well, we look for hyperdense thrombus, which we'll see in 20% of cases, and the cord sign, which may just be thrombus within one of the medullary or cortical veins, or in fact, one of the draining veins. Most common is what we see post-contrast, which is the empty delta of the thrombus sitting within the sagittal sinus or one of the transverse sinuses, with contrast outlining it, showing very nicely the thrombosis. And an indirect sign would be a patient who presents with parenchymal hemorrhage, for which you do not have another cause. When you see edema and hemorrhage, you need to look carefully for the associated venous sinus thrombosis, particularly in a patient with infection. And remembering that in these patients with hemorrhagic infarcts, and when we do MRI on them, they may not show restriction on DWI. So if we do see those hemorrhagic areas, where should we look? So if we see a parenchymal abnormality, and particularly if it's hemorrhagic, and you suspect a venous sinus thrombosis, what are the clues? Well, if we see the abnormality in the frontoparietal or parafalcine region, we need to look carefully at the superior sagittal sinus. Look carefully on the T2 to see whether or not you can see the normal T2 hypointense flow void. And if you can, look carefully for a thrombosis. If you can't, look carefully for a thrombosis. We saw this image on the previous slide. If you see hemorrhage in the temporal lobe, you need to look very carefully at the transverse sinus and the vein of Laby. If we see hemorrhage or we see focal abnormalities in the thalami, look at the straight sinus and the internal cerebral veins. And particularly in neonates, if you see hemorrhagic white matter, you need to look at the internal cerebral and deep medullary veins. And you can see here how subtle it can be, that we are not seeing the nice normal T2 hypointensity of the internal cerebral veins because of thrombosis, and this has caused the hemorrhagic change within the deep white matter. Of course, we can have lookalikes, and what should we look like? This is particularly in the setting of patients with basal ganglia abnormalities, presenting with encephalopathic type signs, focal signs, and seizures. There are other things to consider. I am not going into in any great detail today the multitude of findings in encephalitis, viral encephalitis, but if you do see bilateral basal ganglia abnormalities, you need to consider it and raise it in your differential diagnosis. Particularly in the setting of encephalopathy, and these patients may or may not have a fever, consider ADEM. If it is hemorrhagic, one should also consider acute necrotizing encephalitis. And then if you have got a lactate peak, consider Lee's disease. And these can mimic acute infection and be quite difficult to differentiate on CT. But obviously these patients often, because they're not completely fitting the clinical scenario of infection, will come to MRI. I just want to briefly talk about two things we need to consider with that empty delta sign. The one is that if you see an empty delta sign, you of course have to have given contrast. If you're seeing a so-called pseudo-empty delta sign without having given contrast, consider that it's hemorrhage and then look for additional signs. As in this case, you can see the slightly hyperdense subdural hematoma, and this is another child who presented with non-accidental injury. And then a lookalike that is a normal variant that can look like an empty delta sign is an arachnoid granulation, and the clues are that there's usually a scalloped inner table, it's round, it can have septi, and it follows CSF on all imaging parameters. So it will be the same density as CSF on on CT, and it's going to be the same density as CSF both on T1 and T2 on MRI. And as I said, it can have septi. So another complication that we need to look for, we may be asked to image, is arterial infarcts. So this is particularly common in patients who get meningitis in the first year of life and in neonates. And that is because you get an arteritis because of involvement of the perivascular space and the arterial walls. And because the arteries are that much smaller and that much more vulnerable in neonates particularly, but also in young children. It often involves the perforators and of the anterior and middle cerebral arteries, as well as large branches. So again, these two patients are neonates. One had perinatal infection and presented within the first 2 weeks, colonized from the mom with E. coli meningitis, with group B streptococcal meningitis, and the second one was with E. coli. You can see in the patient with E. coli, we've got more large vessel infarcts, whereas in the patient with group B streptococcus, we've got perforator infarcts, and it's another cause of those bilateral basal ganglia abnormalities that you may see on CT. But in this case, you would probably be dealing with a neonate who had very clear features of meningitis and infection. An important lookalike in a neonate who presents with multifocal areas of low density that look like infarcts, may mimic infarcts, and may have similar areas of restriction on DWI is to consider this condition. There's often brain swelling and white matter involvement, and it's important to pick this up. It's herpes encephalitis, remembering that this is herpes simplex virus 2, not 1, and this is due to contact with infected lesions, usually in the mother's genital tract or birth canal, shortly or soon after birth. If this happens, 30% of them will get CNS involvement, and unfortunately, it's got an 80% mortality rate. So they do very, very badly. And if they do survive, the end stage is usually diffuse edema with encephalomalacia and cystic necrosis. So it's an important thing to even though it has an 80% mortality rate, it's an important thing to differentiate when you have got a patient that's got multifocal bilateral involvement that looks like it may be infarcts. Just to compare, to remind you that HSV1 has got a different pathology and pattern. This is due to reactivation after previous infection. It's spreading along the branches of the trigeminal nerve that innervates meninges of the anterior and middle cranial fossa, and it has particular tropism for the limbic system. So we see that classic, the patient will present encephalopathic, often with a temperature, and the classic involvements, particularly of the temporal lobe and hippocampal and limbic system. But remember, completely different method of infection to HSV2 that we see in neonates. So when we do see infarcts in older children, what do we need to consider? Well, we've already talked about TB. TB gives you the basal meningeal enhancement, thick exudates that surround the basal cisterns, that surround particularly the MCA vessels and cause a lot of perforator infarcts, as we're seeing in this patient. But the other things to consider when we have infarcts as a marker of infection is to consider varicella, HIV, and mycoplasma. So this is a patient that I hope you will realize now has hydrocephalus, has got asymmetrical nodular enhancement in the MCA cisterns, and you can see that a follow-up MRI shows extensive abnormality within the MCA and PCA territories. Excuse me. And this is the DWI and corresponding MRA, which shows you the quite marked involvement. And unfortunately, despite the fact that we can pick these up early, we know to give them, their patients all get steroids, the vasculitic process that is involved with TB meningitis is not improved by any of that. And usually, if they are going to get infarcts, there's very little that we can do to prevent that. So this is a patient who presented with a left hemiplegia, an important clinical history. And when we see this pattern is to ask about chickenpox or varicella, because it can happen anytime from the 1st to the 4th month post-infection. And it's as a result of a post-infectious primary angiitis and often infects the right middle cerebral artery. And you can see here occlusion and beading of that middle cerebral artery post chickenpox infection. And I'm not going to be covering, obviously, chickenpox encephalitis, which would be seen in the acute phase of chickenpox with acute encephalopathy. In my setting, in a country with a very high incidence of HIV, when we see a focal infarct, we always consider that the child may be HIV positive. It's usually due to a primary vasculopathy of HIV. If we have excluded varicella, mycoplasma, or TBM as the cause of it, and we're not 100% sure what causes it, we think it is immune dysregulation causing endothelial dysfunction, and we can have stenosis, as in this case, we can have aneurysms, as in this case, or the patient can even present with a moya-moya type picture. So it's one of the important negatives to consider in a patient who's presenting with an acute stroke, particularly in the setting of infection. So just one thing as a caution, when we have something that looks like a focal infarct, is sometimes we just don't see it. So we have a high incidence of infections in our country, and yet still, sometimes we just don't know. So this is a patient who had focal edema, presented with focal seizures, had a TODS paresis afterwards. There was some concern about whether they should do a lumbar puncture. We saw this focal edema. They were going, is it an infarct? Is it something else? Are we missing something? Well, yes, sometimes on CT we do miss it. So when we look more closely, in fact, this was neurocysticercosis with surrounding edema. And yes, should we, or is this a good use of resources? Probably not, but at least the patient then didn't go on to have an extensive workup for TB or get put on TB treatment, and we were able to diagnose the condition. And interestingly enough, this is what the patient looked like when they came back post-treatment. So the lesion was now dying. We had more edema, but we were now more easily able to see the classic peripherally enhancing lesion with the central dots. Another one that caused us a problem, this patient was HIV positive, very shrunken brain, had this focal abnormality. The patient had presented with signs and symptoms of meningitis. Eventually a lumbar puncture was done that didn't show any features of TB meningitis. It was thought to be a viral meningitis, but we didn't know what this was. So went on to have an MRI 1 month later, and you can see that it actually was an evolving tuberculoma in a patient that was HIV positive, and eventually was discovered to have not been taking the antiretroviral. So when the immune response was then mounted to the TB, we were now able to see the tuberculoma. So when you see that focal edema, I'm sure in your setting, a lot of you in higher income countries, you would go straight to MR, but sometimes we don't, and we get surprises. And just remember that lookalike in patients that are encephalopathic with hemiplegia, we've already alluded to it in the basal ganglia, but when we see gray and white matter abnormalities, they don't respect vascular boundaries, and often with cord involvement, we need to consider acute disseminated encephalomyelitis. So that was a very quick run through infection and giving you some idea of how we manage it in a middle income country, what we see, what we think, and what our guidelines are, and how we would image cases, and what process we go through when thinking about differential diagnoses. Remember always that we're part of a clinical team, and I think sometimes we don't ask enough questions because we're getting all of the requests coming in through risk systems, and we've become a lot less interactive with our clinicians than we used to be. Sometimes it's just not actually worth it to go through the whole dialogue of trying to discuss whether or not a CT or whatever is indicated or not. Remember that the sequelae of these infections and what we can see is going to depend on the stage of brain maturation, whether we're looking at a neonate versus an older child, and the status of the immune system, and it's particularly important for us in the setting of TB. And our diagnosis is really aided by knowing the predisposing causes, our own regional pathogens, what can mimic things, and what things we should be expecting. I would just caution you at any point about telling clinicians that they can lumbar puncture, because they'll ask us to tell them that they can, but it really is their clinical decision based on what clinical findings they have in the child, and not necessarily just on our CT findings. And if the clinical scenario doesn't fit, just consider those lookalikes, because sometimes we tend to head down a rabbit hole that we get into because we haven't been given all the clinical information. And again, image gently, and remember the World Federation of Pediatric Imaging, there are excellent guidelines about reducing your CT dose and about doing limited and fast MRI. So I live on the southern tip of Africa in a very beautiful country, and this is the view that I get to see. Our hospital is in the foreground, and part of Table Mountain is situated behind us. We are always very happy to have visitors, and we have an amazing amount of pathology. So my email is on the very first slide, and I'm sure that you'll be able to access it from Ryan should you need it. And should you have any questions or queries, you are very welcome to contact me. So with that, I am just going to go to the Q&A.
Well, it doesn't look like we have any questions in the queue
Oh, wow.
at the moment, but let's
Okay.
give the attendees a couple minutes just in case anybody does have anything they'd like to ask at the end of your
yeah, I think maybe a lot of people didn't know they were getting pediatrics and thought, oh no. But yeah, hopefully there's, if nothing else, you've at least got the WFPI and .org, and you can try and reduce your doses and do faster MRs.
All right, well, I don't see any questions coming in, so I think we can...
Ryan, just a question. Do you put these onto your website? Because you're very welcome to put it on if you want.
Oh, yes, definitely. We have all of these on demand, usually by the end of the day today. It'll be up on the website.
Great. So anybody that does have a question or something that you want to ask about a protocol or an interesting case, then you are very, very welcome to email me directly. My email is on the first slide.
All right, well, as we bring this to a close, I do want to thank Dr. Kilborn for this great lecture today, and thanks to all of you for participating in our noon conference. A reminder that this conference will be available on demand on MRIonline.com, as well as all of our previous noon conferences. Be sure to join us again on Friday for a lecture from Dr. Karen Finley on masses around the knee. You can register for that at MRIonline.com and follow us on social media at the MRI Online for updates and reminders on upcoming noon conferences. Thanks again and have a great day.